So we'll move now to our third speaker, Dr. Hany Ragy from National Heart Institute, Egypt, and take us the difference between the aneurysm and ectasia management in acute coronary syndrome. Welcome, Dr. Hany.
Good morning, dear professors, chairman, ladies and gentlemen. I would like to thank the organizing committee for inviting me and for giving me the honor to be here today. I'd also like to recognize my young colleague sitting in the audience, Sharif Riz, who provided over 80 cases of ectasia from a series that he had published in the American Journal of Cardiology to be able to prepare this presentation. Yeah, I think he has one of the largest experiences that I've seen. This is an example of ectasia, and even telling the patients that they have a coronary ectasia is now something on the internet. And what is the definition of ectasia? Ectasia is an abnormal aneurysmal dilatation, which is ranging from 1 to 5%. It's a segmental dilatation, at least 1.5 times that of the normal coronary artery next to it, and the difference between ectasia and aneurysm is the length. If you have an aneurysm which is extending at least 1/3 of the coronary vessel, then you call that an ectatic coronary artery. If you have a short aneurysm which is localized, then that's just an aneurysm. I would strongly recommend that you take a picture of this slide and read this paper on the pharmacologic management of coronary artery ectasia by Khidr and colleagues, because it actually describes a lot of pathological origins of ectasia and also some excellent tips on how to manage those patients medically, with a lot of definitions and nice diagrams. This is the paper which was published in the American Journal of Cardiology by Sharif Riz, Galal Saeed, and their colleagues. And many of the cases I'm going to show today are from the series in this paper. This paper was over 50 cases, and they were looking at something very specific, which is what is if some of those etiologies are actually Kawasaki, which survived to adulthood, and we're dealing, and how to differentiate between the Kawasaki etiology and the atherosclerotic etiology. And, you know, in the two main causes of coronary aneurysms are atherosclerotic in adulthood and Kawasaki in the younger age. And of course, people assume that Kawasaki is only a disease of Japan, and, but we know now that we have a lot of undiagnosed Kawasaki in our area of the world as well. Certainly Egypt has Kawasaki. And IVUS was used in that study to visualize the morphology for the difference between Kawasaki disease vasculopathy and typical atherosclerosis. And you can see the IVUS images on top, and you can see the explanation at the bottom, where in typical atherosclerosis, you get the typical atheroma that you see, while in the Kawasaki, you get some fibrosis, possibly some calcification, but you don't get those atheromata. So you get the aneurysm, a lot of thrombi, but no real atherosclerosis inside. Of course, some people who survive the Kawasaki to adulthood might actually develop atherosclerosis. They go ahead and smoke, and they can get a mixture of both. And again, also, which is not terribly important, but the location of where the aneurysm is might help you differentiate between Kawasaki disease or atherosclerotic. And here's, they put a classification in this paper that, you know, which was consistent with Kawasaki, or possible Kawasaki, or almost definitely not Kawasaki and atherosclerosis. And they used, for the sake of time, not going to go through the details on the slide, but they used very intricate IVUS assessments of virtual histology to differentiate between Kawasaki etiology and atherosclerosis. This is a young man who had this aneurysm. And when you see this, there's actually very little that you can do. This patient had flow restored in his LAD and was sent for a lima. And he's young, he's 29, and we believe this is his IVUS. So look at the IVUS. it's a bit on the longer side, but you'll see, you can imagine there's no atherosclerosis, and you'll see the huge aneurysm and the thrombus. There you go. So you could even see it on echocardiography. And again, there are, you see the left main aneurysm with thrombus, by echo. And for those patients, like I said, restore flow and send to bypass. This is an older patient who is from the second group, which is a possible Kawasaki. The total circumflex occlusion, ectasia in the LAD, ectasia in the RCA with aneurysms. Again, it was a failed angioplasty, too much thrombus. The patient was kept on pharmacologic treatment and assessed later, and had some flow. The ventricle was good. The patient had become asymptomatic. The patient was actually left, and 2 months later was angiogrammed and IVUSed and was doing well. The artery, this was the original one on the day of MI. This was 2 months later. The artery had recanalized and it was full of aneurysms. It was IVUSed, and the IVUS showed possible Kawasaki, much less atherosclerosis than anticipated, and areas of aneurysm which only had fibrosis. And his RCA was also IVUSed and studies, and the areas, look at the areas of ectasia in the RCA. They're ectatic, but free of atherosclerosis. This patient was followed up and done well. This is a case of typical ectasia of both the left main and the RCA. And this patient was atherosclerotic, 100% atherosclerotic, as seen by IVUS and virtual histology, and underwent successful PCI. So IVUS can actually be used to differentiate between Kawasaki etiology and atherosclerotic aneurysms, and it should be used in all patients with coronary ectasia to detect thrombi and to show you the etiology. This is, let me go to the next slide. This is the summary of this presentation. If you have coronary artery ectasia, it depends how your patient is presenting. If your patient is presenting with an acute coronary syndrome in the middle, what you want to do is you want to restore TIMI3 flow. You can do it by thrombectomy, by balloon angioplasty, with or without stenting, by intracoronary drugs, and then you see by IVUS, do you have associated stenosis or no stenosis? If you have a lesion, if you just had thrombi, you might not want to put a stent. If you had a stenosis, you can either use a stent, you can use a covered stent if there are no side branches, and covered stents do very well to exclude some aneurysms. You can do some stent-assisted coiling if you have very large areas of ectasia. It all depends what you find, and these are some of the tools that you used. If you don't have a lesion, treat those patients medically, restore flow, and then treat those patients medically with drugs. So this is, again, a patient with left main disease and proximal LAD aneurysm, ectasia, which, again, IVUS was done. And it showed the very large ectatic area. I'll show you in a minute. There you go. And this patient, sorry, I'll move fast. This patient received a stentis, a self-expanding stent. And the area in the middle of the aneurysm was actually, it was post-dilated anyway, but it grew into the aneurysm. So the IVUS afterwards looked really pretty. You'll see here on the right where the stent really grows in the aneurysm and opposes the wall all through. And this patient did extremely well. The left main was then done by standard stenting. You look at the stent here. You see here? The same stent because of this type of self-expanding stents. So again, you need sometimes to use different tools like a self-expanding stent. This was the end result of this patient. And you can see the stent in the middle, in the two lower frames, in different parts of the artery, the stent grows to go up to the wall. Of course, one of the new tools that we have been recently using, both Sharif and I in the same cath lab, is aspiration. Now we have power aspiration using the CAT available to us in Egypt in our cath lab, and some of those ectatic patients, especially with the RCA, they are horrendous, and we aspirate using the pump, and it has given us pretty decent results. I didn't put one of our cases, but we have a few. I just put one which was provided by the industry showing how the CAT works, and I'm sure most of you have used it. Manual thrombectomy does not work very well in those ectatic aneurysms because you almost, whatever you get out, the amount of thrombi is too huge, but mechanical thrombectomy is decent. So IVUS, to summarize, if you have a patient with coronary ectasia and acute coronary syndrome, you should use imaging in all those patients, because imaging will show you two things, two very important things. It'll show you the etiology, and it'll show you that you might not need to stent, and it'll also show you how much thrombus is there. Although IVUS is not so good, OCT is much better with thrombus, but that's what we have available to us. It will also show you the true vessel diameter, because you don't really want to put small floating stents in those very large ectatic arteries. Sometimes you just need to establish TIMI3 flow with balloons and treat those patients medically if you don't have severe stenosis. Self-opposing stents, aspirating device, mechanical thrombectomy devices, intracoronary infusion devices are all very useful, and you should use all your armamentarium, get your tools, and know how to use them, and pray that you don't get a lot of those cases in the cath lab. I mean, Sharif showed me, we actually went through over 50 films, and some of them are pretty scary. I mean, you see them in the cath lab, and you almost say, I wish somebody had given this patient thrombolytic and not sent them here. Thank you very much.
Excellent. Thank you very much, Dr. Hany. Your lecture very clear and comprehensive.